I want to welcome all of our participants here to this panel, Scaling Medical Education. Can New Schools Solve America's Doctor Shortage? I'm really excited to hear from this tremendous panel of experts to help us unpack this emerging topic. I'm Dan Polsky, Director of the Hopkins Business of Health Initiative. HBHI, as we're known, is a Hopkins-wide initiative bringing together scholars from across the university, working together for an accessible and trustworthy healthcare system for the nation that delivers value and affordability to society through a focus on the role of business and incentives. As part of this effort, we host monthly conversations on the business of health, where we bring experts together to discuss emerging issues. So welcome you all to this month's topic. This is led by our moderator, Professor Jodi Segal. She's a professor of medicine in the School of Medicine here at Johns Hopkins, and she also has joint appointments in health policy and management and in epidemiology and in the Bloomberg School of Public Health, and is on the leadership team of the Hopkins Business of Health Initiative. She's a leading scientist addressing health system challenges to ensure care is appropriate and high value. This is an important topic that overlaps her research issues of passion. So I'm going to turn this over to Jodi, who will moderate today's session. Thank you, Jodi.
Thank you very much, Dan. Delighted to do so. As Dan said, we're a collaborative research community, bringing in faculty and students from the schools of business, medicine, nursing, and public health. We do groundbreaking interdisciplinary research and convene scholars, practitioners, and policymakers within Johns Hopkins and beyond. So I'm delighted to host today's webinar, and I've really enjoyed getting to know our panelists, and I'm grateful for your time and insights. Today's seminar was chosen to highlight the growing problem of physician shortages in the US and to deeply explore one potential solution. So before I introduce our panelists, let me set the stage. The American Association of Medical Colleges, AAMC, reported last year that physician demand is projected to continue to grow faster than supply, leading to a total projected shortage of between 13,000 and 86,000 physicians 1 decade from now. This includes a shortage of up to 40,000 primary care doctors. If we're aimed at reducing inequities in care provided to traditionally underserved communities, the U.S. may need more than 100,000 additional physicians. The causes of these shortages are dynamic. There's a growing need with our aging population, but also a supply that is affected by markets, by immigration laws, by the federal funding of residency and fellowship slots, and the production of new MDs and DOs. This production problem can be solved with increasing the size of medical classes and or by making new medical schools. In the last 10 years, including 2015, there have been 19 new allopathic medical schools in the US, including Kaiser Permanente, Bernard J. Tyson School of Medicine in California, and the Hackensack Meridian School of Medicine in New Jersey. Not all of the 19 are fully accredited yet. There's also been the opening of innovative osteopathic colleges, which are often in underserved regions. Today's discussion about whether the making of new medical schools, is likely to be helpful in reducing the physician shortage and, more specifically, perhaps the primary care physician shortage. Today's panelists are experts on this topic. In order of presentation, we welcome Dr. Katherine Kate Mcowen, who's a PhD educator. She's the Senior Director of Medical Education Initiatives at the AAMC, where she works with educational and administrative leaders, faculty, staff, and students across our nation's medical schools and teaching hospitals. We welcome Dr. Peter Bell. He's the Vice Provost at Baptist Health Science University and a founding dean of the College of Osteopathic Medicine in Memphis. He's board certified in family medicine and emergency medicine and has held a dean title at 3 universities. Dr. Robert Cain is the president and CEO of the American Association of Osteopathic Colleges. He previously served as the Associate Dean for Clinical Education at the Ohio University Heritage College of Osteopathic Medicine and has received many awards for his contributions to osteopathic medical education. And finally, Dr. Deborah Prothrow-Stith is the Dean of the Charles Drew College of Medicine and is the founding dean of its new MD program. This is just the fourth medical school at a historically Black university. She built the team, led the planning, faculty development, and fundraising to start the program. Before joining CDU, she was a principal at Spencer Stuart and the Henry Pickering Walcott Professor of Public Health Practice at the Harvard School of Public Health. So with these terrific panelists, I will turn it over first to Dr. Mcowen. So thank you. Thank you, Kate.
Thanks, Jodi. And I'm so pleased to join all of you today, and I'll be addressing that longstanding and well-documented looming physician shortage, a growing mismatch between the number of physicians we need and the number that we're able to train and retain. Multiple independent analyses, including those from my organization, the AAMC, and the U.S. Health Resources and Services Administration, or HRSA, continue to reinforce this fact. Without meaningful intervention, the nation will continue to face a significant physician shortage that threatens patients' timely access to care, especially in rural and underserved communities, as Jodi mentioned. According to AAMC's most recent projections, the U.S. is expected to experience a shortage of up to 86,000 physicians by 2036. This includes shortages of up to 40,000 primary care physicians and up to 20,000 specialty surgeons. HRSA's federal modeling shows even larger gaps of 124,000 physicians short by 2027, growing to 187,000 by 2037. These shortages will be felt most acutely in non-urban and rural areas, particularly in primary care specialties where access is already quite strained. There are complex and long-standing reasons why the nation faces this reality, and I'm going to focus on a few of the primary drivers. First, the demographic reality of the current physician workforce contributes significantly to projected shortages. 1/5 of all practicing physicians today are 65 or older. Another 22% are between the ages of 55 and 64. In other words, more than 40% of today's physicians are at or approaching the traditional retirement age. As these physicians reduce their hours or leave their profession altogether, the workforce will contract in ways that current training pipelines cannot replace quickly enough because of the time it takes to train a practicing physician and who we use to train the physicians. We also can't forget the COVID-19 pandemic's long-term impact, which is still unfolding, and early evidence suggests that burnout among physicians is leading to both early retirements and accelerating workforce exits. At the same time, patients' needs are growing. By 2036, the overall U.S. population is projected to grow by 8.4%, but the population aged 65 and older will grow by 34%, and adults 75 and older by more than 54%. Older adults are use far more physician services, particularly specialty care, and advances in medical treatments mean that people are living longer with chronic but manageable diseases, improving longevity, but increasing long-term demand for care from physicians. And finally, the well-documented bottleneck of residency training positions relative to the increasing number of possible trainees. Residency training is required for licensure, yet the number of Medicare-funded residency slots has grown very slowly since they were capped in 1997 under the Balanced Budget Act. While medical schools have expanded enrollment by nearly 40% since 2002, residency program training opportunities have not kept pace, particularly in the primary care specialties. This bottleneck limits the number of new physicians entering practice each year. To add some context that is important to understand the problems we face in rural areas of the U.S. where shortages are most severe, more than 43 million people live in rural areas with primary care health profession shortages. By 2037, rural primary care physician supply is projected to meet only 68% of that demand. We have also seen a troubling decline in rural family physicians, an 11% national decrease between 2017 and 2023. This is happening precisely at the same time that young adults are moving to rural areas at the highest rate in nearly a century. Because rural physicians often provide not only adult primary care, but also emergency care, pediatrics, labor and delivery, and minor surgery, the loss of even one physician can dramatically impact an entire community. Another important note is that international medical graduates make up 25% of the US physician workforce and disproportionately serve in rural communities and in critical shortage specialties such as primary care and psychiatry. The recent increase in H-1B visa fees from $3,500 to $100,000 will make hiring IMGs more difficult for cash-strapped hospitals, especially those rural ones, which may worsen existing workforce gaps. Despite these challenges, there is some meaningful progress. The federal government is responding by funding the first increases in funded residency program positions since 1997 through the Consolidated Appropriations Act of 2021, which is adding 200 new residency slots annually between 2023 and 2027, as well as an additional 400 slots targeting primary care and psychiatry, which were added in December of 2025. And finally, it's important to note that the Resident Physician Shortage Reduction Act, endorsed by many national organizations, including my own, was reintroduced in 2025 and is currently in committee in both the House and the Senate. It would add 14,000 federally funded residency slots over 7 years, really impacting that bottleneck. The physician shortage is real, persistent, and confirmed across every major workforce projection. But we also know what works: continued investment in physician training, like we're going to talk about today, and targeted support for rural and underserved communities. Policies that support a stable and diverse workforce can change our trajectory. With sustained commitment, we can ensure that every patient, regardless of where they live, has access to the physicians that they need. Thanks. We'll turn it over now.
Thank you very much, Dr. Mcowen. That was disturbing. I'm glad you ended on some bright notes. And I do want to welcome everyone to put questions in the question and answer section that we'll get to. Thank you. And we turn to Dr. Bell.
Thank you, Jodi. Kate, that was great. We obviously share some of the same information, and there may be a little bit of overlap. So let me see if I, in the next 6 minutes, can address physician supply in rural communities, maldistribution in those communities, touch on some barriers to establishing med school and rural health in those areas, and I'm going to add some strategies. So for most folks, you wouldn't necessarily know this, but currently 20% of the U.S. is rural. While I think Kate mentioned 10% of physicians practice in rural communities. You can see the mismatch right there. We have 56 primary care docs per 100,000 in rural areas versus 94 in urban areas. Of those practicing in primary care, you mentioned IMGs. So DOs and IMGs are much higher or larger representation, around 20%. And I concur with you about the decrease in primary care in rural areas. Before the pandemic, we saw things decreasing, and it's gotten worse post-pandemic. People are leaving rural areas. Also for us, because we're here in Memphis, we cover the Mid-South. 2/3 of Mississippi is covered by our healthcare system that's part of our university. We're seeing hospital closures, and the hospital system itself has been looking to shore up opportunities for patient access in those areas. So what does the current supply of physicians look like? So we had approximately 40,000 first-year GME spots this past year in the National Residency Match Program that were filled. Out of that group, 21,000 MDs, 9,000 DOs, again, round numbers, went into the match program. The gap in that was filled by international med grads. And let me say, that has been part of the US strategy for a long time. We do not produce enough of our own. And so we've been relying for a long time on those international grads. And I concur about the barrier you just mentioned. If the visas are going to cost $100,000 or whatever, that's a huge cost. In terms of statistics, out of those 40,000 first-year slots, about half went into family medicine, internal medicine, and pediatrics. 34% were filled by MD, USMD graduates, 54% by USDO graduates, and 83% by international med graduates. So you can see why, with those numbers of DOs and international med grads going into primary care slots, the likelihood of them being higher represented in rural areas is there. So who enters primary care residency doesn't actually tell us the whole story. There has to be some accountability, because we know a lot of primary care docs say, you know, I really enjoy general internal medicine, general pediatrics, family medicine, but they end up doing fellowships and subspecializing. And what we really need is generalists doing general things like it used to be when I grew up. When we see our general surgeons doing fellowship after fellowship, or our orthopedists becoming just knee doctors, that's a problem. We need more generalists, and we need to have accountability for what happens to our graduates, not just assume going into the pipeline that they're going to come out and do their primary board specialty. I also note for the ACGME residencies, only 14% of the residencies are in rural areas. So we really need to increase the presence of residencies in rural areas. And yes, the Balanced Budget Act of 1997 was a real blow for us in trying to create new programs. Although, as I think my colleagues know, there are other pathways other than getting CMS dollars that we pursued. I also looked at statistics. I was interested in where graduates from various schools were going. U.S. News and World Report in 24 had listed the top 10 U.S. med schools where graduates graduate from and go to rural areas. 9 out of 10 of those schools were in rural areas themselves, and 6 out of 10 were DO schools, which historically a lot of DO schools have been started in rural or smaller communities. In terms of barriers to establishing a med school, and I'm sure Deborah's been through some of this, and we have several colleagues, MD-DO schools, who have faced the challenges in the last few years. If we're looking at a rural community, geographic isolation has always been a problem. What do you do when your spouse is looking for your job, or your kids want to go to school, or you got to have high-speed internet? So that has been a barrier. Financing. Who's going to fund it? I think when we get to question and answer, we can talk a little bit about the different models that are out there. You need to have some existing infrastructure to help support. It's hard to do it, from a cornfield up. You really have to have something already present. And faculty recruitment. I could tell you my stories, but everybody that I talk to that are deans at med school say, boy, faculty recruitment was kind of hard before the pandemic, but boy, is it hard now. We don't have enough people in the service part, and we certainly don't have enough people in teaching either at the med school or for our residencies. In terms of strategies to promote rural practice, there are a lot of articles out there that some are speculation and some are data-based. First and foremost that comes up frequently is if the school has a mission on primary care, rural and underserved, they tend to be much more successful because they want to make their mission happen. You need to recruit students from rural areas. You're 3 times more likely to return to practice if you're in a rural area. One article was being very optimistic about 10 times. I don't think so. But 3 times, yeah, I can buy that. Establish rural clinical rotation. So often we get stuck at big city hospital or think that the local community hospital that maybe doesn't do tertiary care, but they're doing primary and secondary care. Well, why would we rotate there? Well, there's a lot of medicine, majority of medicine that happens in rural clinics and rural hospitals. Develop community relationships. Don't just rely on the infrastructure that exists, but go out there and meet those people that have the most needs. establish residencies in rural areas. Again, 14% of ACGME programs are in rural areas. And I mentioned tech before. You really have to have high-speed internet. We were working on a project for placement of rural physicians, primary care in the Mid-South for the Baptist system. And part of the plan is establishing high-speed internet services and technology similar to urban areas so that they have at their fingertips the tools they need and were trained on to take care of their patients as if they were in the highly served areas. And then loan forgiveness. Oh my gosh. Now, let me say the literature, loan forgiveness is great if you're from a rural area. The literature did not support that loan forgiveness programs necessarily motivated people to go into primary care or to go into rural care unless they were already from a rural area. And then a few last comments. Since Deborah and I are both founding deans at med schools, what's my experience? Well, Baptist Health Science University, College of Osteopathic Medicine did open in the summer of 24. It was a 10-year project that the system was doing here at the university and within the Baptist Memorial Healthcare System. We have 26 hospitals and over 200 clinics in the Mid-South, and we are heavily rural. We cover Tennessee, Arkansas, Mississippi. 35% of Tennessee's rural, Arkansas is 45%. Mississippi, poor Mississippi, they're 55%, and they are way down on the bottom of the list for healthcare and access to care. 2/3 of Mississippi is Baptist Memorial Healthcare Systems. We established that we would recruit from the region. More than half the class is from that footprint, and we are heavily rural in terms of who those students are. For our clinical training years that start this summer, we've established 8 clinical training sites. They are predominantly rural and underserved. Our students will be there for all of their third-year requirements. We also established 10 residencies. There's more in the pipeline. 2 family medicine, 1 with a rural clinic, and 4 internal medicine residencies, all rural underserved areas. And this year, we're launching our tuition deferral program for those people who are going to be practicing eventually in that service footprint. So I know we end up with a lot of people saying things, but for my key performance indicators, we lined all these things up that if we said it in the mission, we better do it. And the mantra around here has been, we're going to recruit from the Mid-South, we're going to train in the Mid-South, and we're going to retain them in the Mid-South. Thank you all.
Yeah, terrific. Thank you. And I'll encourage the panelists to look at the Q&A. And if there's anything that you want to answer directly, to type in the answer, that's fine. Thank you. All right. Thank you, Dr. Cain, please.
All right. Well, thank you, Jodi. Certainly some interesting thoughts from Kate and data from Peter. I'm going to take a slightly different direction as we move into this next section. So I've been asked to address today's topic through the lens of medical education as a business opportunity and ROI for the community. Significant concern exists about investor-owned medical schools, including the quality of education, the student experience, and stability of ownership. Are there potential challenges? Yes, but there are also challenges with other funding models. I want to begin with a simple observation. Applicants today are not naive consumers of medical education. They're sophisticated, data-driven, and acutely aware of risk. When they evaluate a medical school, especially a newer or investor-owned institution, they're asking if this school will get them where they need to go. For investor-owned institutions to remain competitive, they must deliver outcomes that are as good as those of state-supported and nonprofit schools. Let me highlight a few that matter most, and these are really through the lens of the student and thinking about the role of this type of school. First, and there's no substitute for this, a strong residency match rate. For applicants, match rate is one of the clearest proxies for educational quality and institutional credibility. They want to know not only that their graduates match, but where they match and in what range of specialties. Investor-owned institutions must meet or exceed national match averages and be transparent about results. If a school can't clearly demonstrate that its graduates move successfully into residency, nothing else matters in their brochures. Second, in the case of osteopathic medical schools, complex performance and academic support. But the same is true if we were to consider USMLE. Applicants understand that licensing exams are a gatekeeper. Strong first-time pass rates on complex level 1 and level 2 and scores that track with national norms are a signal. Equally important is the infrastructure behind those numbers: early assessment, robust tutoring, and faculty engagement. High-performing schools don't just select strong students, they systematically support them. Third, the quality and stability of clinical training. This is where newer schools, particularly investor-owned institutions, are scrutinized closely. Applicants are wary of uncertain rotations, excessive travel, or last-minute site changes. To earn trust, schools must guarantee core rotations, maintain durable hospital and community partnerships, and offer exposure across a broad range of specialties. Students know that clinical training shapes their professional identity. If that experience feels fragmented or transactional, applicants notice. Fourth, demonstrable graduate outcomes beyond the match. Applicants increasingly ask, what happens after residency? Tracking and sharing graduate trajectories, especially placement in primary care, rural practices, and underserved communities, reinforces credibility and can help to demonstrate mission alignment and attention to the public good. And finally, the student experience itself. This generation of learners pays close attention to advising services, wellness support, faculty accessibility, and institutional responsiveness. Investor-owned institutions must show clearly that students are treated as future physicians, not revenue streams. Strong career counseling, mental health resources, transparent communication, and visible leadership engagement are not extras. They're baseline expectations. Now let me change directions here, because this is where skepticism often enters the conversation. Some ask whether investor ownership changes the responsibility of a medical school. The answer is no. Accreditation standards do not change. Ethical obligations do not change. The expectation that graduates are competent, compassionate, and prepared for residency does not change. Ownership structure may influence financing, but it does not alter accountability. A poor product is visible, is not attractive to potential students or employers, and is risky for the investor. When schools get the balance right, the return is not limited to students. A recent 2025 AAMC Workforce and Economic Impact Report showed that colleges of osteopathic medicine generate substantial economic impact for their host communities, collectively supporting thousands of jobs, attracting health system partners, and anchoring physician workforce pipelines. Communities that host a College of Osteopathic Medicine, or COM, retain graduates, improve access to care, and strengthen local health infrastructure. If you have a COM in your state, 36 states right now, roughly 40% of graduates stay in the state and become available to you in some capacity. 3 out of 4 entering primary care or a high-need specialty. That's a return on investment that extends well beyond tuition revenue. And it does not change significantly based upon investor-owned, state-supported, or nonprofit status. We do not need to lower standards to scale education, and we cannot protect quality simply by refusing to expand capacity. The work is in doing both, thoughtfully, transparently, and responsibly. We also cannot continue to be limited by a 1910 report that decried proprietary models and community-based education. Investor-owned COMs can be a part of the solution to America's physician shortage, but only if they consistently deliver the outcomes applicants care about most and commit to a mission aligned to the public good. That's the standard applicants expect, and it's the standard communities deserve. Thanks.
Thank you, Dr. Cain. All right, and we'll go to Dr. Prothrow-Stith.
So, hello, everyone. Thank you so much for hosting this conversation. It's a much needed conversation. I'm going to start by talking a little bit about CDU and our context. So, the Charles R. Drew University of Medicine and Science is a nonprofit, non-sectarian school that is 60 years old this year. We have a nursing school, a college of science and health, and a college of medicine. I've been dean of the College of Medicine here for almost 10 years, and I was hired with the goal of starting residency programs, I should say restarting residency programs, and starting our new medical school. I think a lot of what has been shared about the struggle, particularly Peter's comments, really resonates with the experience that we have had. CDU is located in South Los Angeles, an area of 1 million people, and we're the only medical school in this area. We represent an urban, underserved area, which often gets left out of some of the more recent conversations. We are located in an area called Willowbrook, which is just south of Watts, borders the neighborhood of Watts, and just north of Compton. So the city of Compton and the neighborhood of Watts are our neighbors. When we started residency programs initially, that was a state-funded initiative to respond to the Watts Rebellion. Some know it as the Watts riots. We call it the Watts Revolt. But the building of the Martin Luther King Hospital represented the state's response to that. And CDU was started to train residencies at that hospital, to open residencies and train residents at the hospital. In 2007, some many decades later, the hospital closed. And when I arrived at CDU, restarting residencies and the new community hospital, now the King Hospital again, was to host some of those residencies. At this point, we have psychiatry, family medicine, internal medicine, physical medicine and rehabilitation, child and adolescent psychiatry fellowship, and an addiction fellowship. And we've opened a new medical school. Our first class entered in 2023. We will graduate our first class in 2027. We're in that LCME process at provisional. Our next survey is in a year, and it will be for full accreditation. My answer to the question raised by this panel is yes, new medical schools are part of the solution. However, as a country, we have not decided that that is the case. We don't have a plan for this physician shortage, well documented by Kate and Robert. It's just part of what we are facing as a country. And I think the plan around GME, or graduate medical education, and CMS's investment in that is important. However, where will the residents come from if we don't have the medical students? So part of this is new medical schools, and I think underserved areas represent the appropriate geographic distribution for new medical schools. Obviously, increasing the size of the current medical school classes is also a part of what we need as a country, and the importing of physicians, often a brain drain from countries that need those physicians, remains a part of our strategy. One of the striking things about starting a new medical school, and I've shared the context, one of the striking things about it is the lack of funding for medical students, for medical education. Unlike GME, where we have a federal policy and we have an investment, we really don't at the national level have a policy. We have federal loans, and even now that's under attack. So it's no surprise that one of the ways that we have not successfully diversified medicine is socioeconomics. If you look at the reports over time, there is a recalcitrant relationship between family income and getting into medical school. 70% of our students, and we have 60 per class, and we are accepting our fourth class now, receive Pell Grants in college. So we are able to diversify medicine by socioeconomic status. However, nationally, that number is 20%, some 15 to 20%, depending on when you look at it. So I think it is a challenge that we as a country have, not just around issues of geographic distribution, but also just about the evidence-based medicine that comes from such a skewed group of medical students. And as a country, I think if we're going to address rural issues, if we're going to address family health issues in low-income families, this issue of diversifying the medical student population is critical. I do want to point out, and I will end on this, some of the ways that we were able to be successful and some of the lessons that we learned. It was very helpful that we had a 40-year history of partnering with UCLA in training medical students. That set a nice platform for our independent medical schools. Very helpful that we were starting in the context of a university. And I know a lot of medical schools are starting from scratch. So things like financial aid and HR and admissions, those were things that we had as a university familiarity with. I have to say, we have had longstanding state and county support, and it was very helpful to be able to build on that support. I think that support reflects the community that we're in and the support the community has for us. And so one of the big lessons is you can take your surrounding community's support to the bank every time, whether it's the political bank or the private bank. And so the time you spend, working out your plan and working with your community can be very, very, very important. We received a $50 million award from the state to build a new building. We've raised an additional $30 million on that, and we will be opening our new building in May. And the economic engine for not just the building, but that is created by the medical school is beginning to be very obvious in the community. So yes, new medical schools are part of the answer. As a country, if we really want to maximize the potential of new medical schools, then there's a investment and a seriousness that we have to approach this. Right now, every new medical school is on its own from the national perspective, and that probably needs to be addressed. Thank you.
Thank you. All right. Well, this is terrific. There's been very interesting questions put in the Q&A section, some of which are focused on medical schools, some of which are broader about the physician shortage. So I think I want to keep it a little bit narrower right now and still keep the focus on the schools and the production of new schools. I'd like to just follow up with some questions that came up during our pre-meetings, which I hadn't really thought about much. You talked about it, well, a little bit, both Peter and Deborah, about community-based medical schools. Certainly, I did my training in university-based programs and wasn't so aware even of community-based schools and the challenges that they face. Do these seem viable, or is it more likely that there will be growth of university-based programs with satellites? What seems like the more likely path ahead?
It's an
Can I go
interesting.
first, or do you want me to jump in?
You can go ahead, Peter. It's an interesting question. Yes.
So Dr. Cain is quoted last year in the Lackawanna College news report. AAMC partnered with Scranton to start a medical consortium in that community. To long-term hope is that establish ties to the community to also pursue a residency here with the right center and eventually place in students in practice in the region. I think partnerships, it could be an established university in an urban setting, it could be a tertiary hospital system, but going out and, as I said, going to that community, establishing relationships and saying, will you help sponsor med students? And that goes back to the funding issue. If we base med students here in your community hospital, because remember, third-year med students, it's more bread and butter. We're not talking about deep tertiary care. So it's highly doable. It's possible. As far as satellite, yeah, I mean, if you have infrastructure already in place and you don't have to duplicate, all the leadership positions, and we're using telemedicine and other mechanisms to train, yes, I would say that's highly doable.
And that's growing, right?
Yeah.
That regional model with satellite campuses.
I think we're in a situation, again, without any federal or national policy and modeling, where, when you've seen one new medical school, you've seen one new medical school, even if it's a regional or a satellite situation, because that local buy-in for now is so critical. It's all responsive to need and bubbling up with community support, at least in the nonprofit context. I suspect that the investor may be able to catalyze some community support and some growth in ways that the nonprofits are really dependent upon government or philanthropy to seed or to catalyze. But it's an interesting question, and without a national model, I don't think we can even answer the question as to which is going to expand, further.
Well, there are two comments here about federal investment through HRSA, the medical school education grants. Can anyone talk about that program at all?
We do have HRSA funding, and it is extremely helpful. It does focus on primary care training and residency training. Some of it also focuses on other primary care providers like PAs and nurse practitioners. So I think that it is part of it, but it is also that competitive application process that does influence what model you have. But doesn't represent what HRSA is doing is very helpful, but it doesn't represent a national model around medical education.
Jodi, may I?
Please.
So I think one of the interesting things about your question is that sort of letting the thing speak for itself in some ways, right? So first, to Deborah's point, there is a need for language, understanding language or translation of language between different settings. Are we talking about 4 years of medical school in the community? Are we talking about 2 years with the third and fourth for clinical? And understanding how all of those pieces can fit together. But if we look at the collective experience between the DO and MD communities, we've utilized this space for 130 years. The MD community starts in the mid-1970s, so at least 50 years. And the growth has continued in both spaces. And there really aren't a lot more spaces to open medical schools in association with large university hospitals. So it almost makes this a primary place for development as we move forward. And in particularly with the service orientation, right? We can have a science and research orientation in one space, a service orientation in the other, and hopefully through that create a much more complete healthcare system and delivery. And I think that's what Deborah's getting at. Is like, what's the plan and how do we use these pieces most effectively?
Especially with our community medical schools, which are not based like CDU with a large academic teaching medical hospital, but reliant upon a number of clinical and community-based hospitals.
Well, is some of this plan affected by the accreditation requirements? There were a couple questions about accreditation changes that are coming in the near future. Is that? I can't speak to that. Would someone?
So we've seen LCME and COCA, which are LCME for MD schools and COCA for DO schools, get a bit more granular about what their expectations are. They, as was said earlier by more than one of our speakers here, we have to turn out a product. There's got to be accountability. We can't dumb down the product. We have to make sure science is advancing so quickly and patients are expecting that we're keeping up with the latest innovation. One thing we're doing here is we talk about high tech, high touch. We don't want them to lose the patient focus, but at the same time, we want them to be on the cutting edge of what's out there to be able to better take care of their patients to prevent injury, illness, restore health, maintain wellness. So the accreditation piece is helping keep us honest.
There's certainly an awful lot of uncertainty about what will happen with accreditation. And so those may be things that, we're going to have to learn about, deal with, and so forth as they unfold. I think that COCA, the Commission on Osteopathic College Accreditation, has demonstrated an ability to maintain high expectations for new schools to produce a quality product, while describing an environment that is sort of outside of the Flexnerian image of what medical education should look like. And those new rules, as they put them in place, have not really impeded growth or expansion, despite changes that are intended to maintain quality and to integrate, as Peter's saying, emerging technologies and teaching methodologies.
I think the LCME process for a new medical school is rigorous. The preliminary accreditation, which allows you to accept students, is generally a 3 to 4 year process for the planning group, an active 2-year process, I would say. They come again. Basically, it's an every 2-year survey visit until you get to full accreditation. The standards are as they are for the other MD programs when you get to full accreditation. And I do think they are striking that balance and allowing mission-driven reasons for starting a medical school to not overshadow the rigor that's required and the student performance that is required. And it's really, I like to say that LCME becomes your best friend when you open a medical school and you see them every 2 years until full accreditation. And I do think that it's an important part of who we are and maintaining the quality of the product, whether we are not for profit or for profit. The LCME plays a tremendous role in the issues of quality.
So certainly the cost of medical school education comes up a lot, and now the cap on student loans is very pressing. Would anyone like to speak to the the wisdom of reducing medical school education from 4 years to 3 years?
So I would like to address a little bit about that. I'm not sure that reducing medical school to 3 years necessarily makes medical school less expensive. It would reduce 1 year of living expenses, but typically the education of the tuition remains the same. So it is about reducing living expenses, and so it can be cheaper. I think the AAMC has been looking at this problem and thinking if there are ways to work as a community to provide support for learners, because as I think Deborah mentioned, we already have a problem in medical education, particularly in MD granting institutions, where the overwhelming majority of students come from the top 2 socioeconomic strata already. And as we talk about diversifying our workforce, particularly preparing a workforce that can serve the entire nation, we have to address these issues head on so that any student who's accepted to medical school can attend. And 3-year medical schools or programs that have 3 years, there's not that many of them yet. So to ramp it up, to prepare it, I don't know that that might be a very long-term solution. I don't know that it's going to be a solution in the very near future. So thinking about other ways to address these changes in financial aid policy so that any student who's accepted to medical school can attend, and schools can focus on creating the medical student population that will best serve their communities, I think is our primary goal.
That sounds fanciful. That sounds fanciful.
Let me jump in here. I've been telling everybody, going to med school is like sprinting a marathon. Trying to compact 4 years in 3 years and get the faculty to actually do it, forget it. Yeah. What we have looked at is, well, maybe that instead of completing 4 years of a bachelor, maybe you get credit during the first year of med school for criteria that gets you that bachelor's degree, or accelerating people 3 years of med school and then accelerating into a residency program type platform. That seemed more viable in terms of cost and saving time, but med school is so stressful. Looking at the 3-year programs, you really have to have a very select group of students who are going to endure. There's just so much you have to learn in the time allotted. So you have to have a lot of resistance. And do you normally sprint a marathon? No.
I think the interesting data we learned was that something like 81 or 82% of the students who enter a 4-year program graduate in 4 years. 96 in 5 years and 98 in 6 years. So I don't think shrinking it to 3 years is going to really help us with issues of diversifying medicine and underrepresented groups, because in addition to the volume of information, there's an acculturation process, a kind of professionalism process that, is part of the learning as well. So in starting our medical school, we intentionally kind of bucked the trend of trying to shrink it down to 3 years. And we're preparing for students to take 5 years and trying to figure out how not to have them charged for 5 years, not tuition of 5 years, but if 20% nationally it's taking 5 years, I suspect we will, and new medical schools will at least have that.
Well,
Sorry, go ahead.
I want to turn to a different topic slightly. So you had brought up, or someone brought up, right, the difficulty in recruiting faculty specifically to teach in rural settings if they're not from that area. One of our comments is about the quality of medical education, the quality of the teachers. So if you're using community-based clinicians, how do we assure that they are teachers and have those skills?
I'll just say quickly, it's really getting training and faculty development. I think with the LCME requiring of us that those who teach medical students are faculty, we have to make sure that we onboard them and involve them in faculty development. And I would just add quickly that it's not just the individual, it's also institutions that are willing to be academic in their clinical care, but what that means and how we create an acceptable academic environment in those institutions is also part of the work.
Yeah.
And I'll add that I think that there can be a benefit if medical students are training in a place where there aren't many residents and many fellows. They have an opportunity to form a direct connection to physicians in the community setting. It provides them an opportunity for observation that isn't afforded to every medical student. So I think thinking perhaps a little differently about the benefits of community training is important to really understand the full picture.
I can get to do more.
All right, we have just a couple minutes. There was just one, there are many interesting comments. What about not making our own medical schools and we send more US citizens abroad for their medical education and then they come back to us for residency? What does that look like?
So I've been working with Trinity College in Dublin and Royal College of Surgeons in Ireland, University of Birmingham, University of Plymouth, Oxford, mostly the UK and Ireland system, and they have capacity limits. They have lots of international graduates coming in that were part of the British Empire. We have about 2,500, 2,500, 2,700 US citizens who go international and then come into the residency programs each year. So that is happening. And we have offshore medicine as well, but you would have to get them to expand the number of slots, and I think they face some of the same challenges we do.
Yeah, I didn't know those numbers. Mm-hmm.
I'll also suggest that a medical school in a community adds value, significant value that we'd be letting go of if we were sending our problem outside of the nation's boundaries.
Mm-hmm. Good. All right, everyone can have one closing sentence, one sentence. Dr. Cain?
Oh, well, from a standpoint of the investor-owned schools, I think since that was my focus, Opportunity exists to be open to innovation and a variety of different pathways that can hopefully help us solve this problem. There's no one way to increase the number of physicians we need in the US.
Very good. Dr. Bell.
Hope eternal. I'm an optimist. I think we can solve these problems if we work together.
Dr. Prothrow-Stith.
I look forward to a national agenda around the physician shortage and around primary care. I saw the question about PAs and nurse practitioners, and that's just an important part of the conversation. So future conversations and a national policy.
Yeah, I agree. Dr. Mcowen?
Yes, I agree with all of the panelists here today. I think they're an excellent representation of the minds that are at work trying to solve these problems in every sector of the nation. Large organizations, community schools, regional campuses, they all knit together, I think, to think about how we solve this problem. So I am also an optimist, and I think we'll just keep plugging away at it.
Great. Well, thank you very much to our panelists, and thank you to Hopkins Business of Health Initiative for hosting us. The recording will be on the HBHI website if anyone wants to listen again. And thank you all for your really interesting comments in the Q&A. I wish we could have gotten to all of them. So thank you very much. Have a good day. Stay safe in the snow.